as they're able to. So good evening, everybody. I'd like to welcome you and thank you for joining us at our opening doors conversation about COVID-19, vaccination in pregnancy, breastfeeding and fertility. Thank you. Next slide, please. So my name is Sandy Richards and I'm a midwife and I work for the Bath and North East Somerset, Swindon and Wiltshire local maternity and neonatal system. And I'm delighted to welcome some of my colleagues here tonight from across the area. So I'd like to introduce you to Dr. Jo Baden Fuller, who is a consultant obstetrician at Salisbury Hospital, Dr. Colin Payton, who is a clinical support manager for BSW CCG and also a consultant occupational physician, Dr. Catherine Aldridge, who is a GP in Swindon and is also our GP maternity lead for BSW CCG, and obviously myself. We were going to be joined by Jenny, who is a mum from our local area who's pregnant, but unfortunately she wasn't able to join us. But she will be here with us in spirit and has done us a video. So we're hoping to be able to show that to you this evening as well. Thanks. Next slide. So I thought it would be useful if we just briefly go through the planned format for this evening's webinar so that you know what to expect. We're really pleased to be here today to have the opportunity to provide you with some facts and information about vaccination in pregnancy that you might find useful to consider and to give you an opportunity to ask any questions that you have. We appreciate that you may have worries or concerns and we're hoping that by sharing the currently available evidence and our experience that this will help you to make an informed decision about what's right for you and your pregnancy. With this in mind, we plan to start by listening to Jenny's story about the thoughts that she had when she was deciding about whether to have a vaccination in her pregnancy. This will be followed by Dr. Baden Fuller, who will be talking about COVID-19 and some of the risks in pregnancy with COVID-19. Dr. Payton will be explaining about how the vaccination works and taking a look at some of the science and safety aspects of COVID-19 vaccination. And Dr. Oldridge will be providing some information around vaccination timing and access. Through the session, we will be presenting some facts and data, and we want to say that we really do understand how difficult it feels to be pregnant and have to be making decisions about having something that is going into your body when you have a developing baby inside you. We want to reassure you that we're not giving you the data that follows in this presentation in order to frighten you in any way or attempt to coerce you. We're here as clinicians and what we want to do is to support you to understand about the potential risks and benefits so that you can weigh these up and make the right decision for you. One that's based on available information and evidence so that when you make your decision, you do so from a fully informed perspective. We also want to reassure you that whatever your decision is, we will always continue to provide the same care and support for you throughout your pregnancy. During this presentation, we have used the term pregnant women, and this includes those pregnant people who do not identify as women. We would ask that during the presentation that if you have any questions, could you type them into the question and answer box as we go through the presentation. Your microphones will be muted during the presentation. When you post the questions, please feel free to either use your name or to post anonymously, whatever feels most comfortable for you. Even if you think it's a really daft question, please ask it, because we can guarantee if you're thinking it, then somebody else probably is too. At the end of the presentation, if we haven't covered your question in the information that we've given you, then there will also be an opportunity for us to take questions using the hands up function. We want to say that we're not putting ourselves up forward today as total experts, and we cannot promise to have all of the answers. So if there is a question that we don't know the answer to, we will be honest and we will say so, but we will endeavour to find you that information if it's available and share with you after the webinar if you're happy to provide contact details. We also want to say that we will be recording the session today, and this will enable others to access this as a resource. Your faces will not be shown on the recording, and as we said, you will have the opportunity to ask anonymous questions if preferred. Thank you. For the next slide. So to begin today, we wanted to ask you a very quick question, just to get a little bit of a sense about how you're feeling about COVID vaccination in pregnancy. So Ruth is going to post a question on here for you. And what we'd like you to do is just to click on this box in the screen in the one that most describes how you feel about COVID-19 vaccination in pregnancy. Just going to give you a few seconds to do that. This is where we're hoping the technology is going to work. Is that coming through, Ruth? Okay, so looking at how we've got quite an even split today of people who have a range of feelings around COVID vaccination in pregnancy, so fairly equal across the board. So thanks, Ruth. We'll close that, and then we're going to come back to that question at the end of the session today to see how you feel after the webinar. Thanks, Ruth. Go back to the slides. So what we're going to do now for the next slide is we're going to introduce Jenny to you, who is a mum of 2 boys, who lives locally. She lives in the Swindon area, and she's pregnant with her 3rd baby. And in the video clip that we're going to show now, she describes her story of the process of making a decision about vaccination in pregnancy. Just give us a moment while Ruth loads the video. This is where we're all hoping, here we go. Here's Jenny.
Hi, I'm Jenny, and I've been asked to talk to you all about why I was happy to have the COVID vaccine in pregnancy. A little bit about my journey. So my husband and I decided to try for our 3rd baby just as the pandemic hit. So like everybody, we were watching, listening about all the guidance and evidence about COVID. And when the vaccination programme came out, initially the advice was to not have the vaccination if you were pregnant or trying to conceive. I work in the NHS, I am a midwife, so I was very aware of the information available to me. And as all my colleagues started to get vaccinated, I held off. Unfortunately for my husband and I, it was a long journey to conceive, and in that time obviously information changed. Now I've got 2 boys already, both are in school, and obviously everybody knows that schools are a high contact area for COVID and also the NHS. So I had to keep in mind about protecting myself and my family, especially as it'd been over a year of us trying to conceive a baby. So my husband and I sat down, looked at the new evidence, thought about all the information available to us. I was worried about the fact that if I didn't have a vaccination, that I was at higher risk of a premature birth when I did conceive, that I was at higher risk of an emergency section. I was happy with the fact that there was no information available to say that actually the vaccinations had caused any harm to any babies. I needed to weigh up all that information to make my decision. And actually, because I didn't know when I was going to conceive, I decided back in May to start my vaccination programme. And lo and behold, a week later, I find out I'm pregnant. So I've had my first dose, and I then find out that I'm actually pregnant. So I then had my second dose in September, and that's actually when the information was more available and was really encouraging pregnant women to have the COVID vaccination. So by that point I was very happy in my decision that actually by September, 17 weeks pregnant, I would have protected myself and my baby against the risks of COVID, with information available to me actually that there was no adverse effects for having the vaccination.
Thank you. So it's lovely to hear from Jenny, and I'm going to introduce you to Jo now, who will be talking us through some of the impact of COVID-19 on pregnant mums and babies. So over to Jo once we just share the slides again.
Whilst Gemma's loading them up, I'll just say I'm Jo Baden Fuller. I'm one of the obstetric doctors from Salisbury Hospital. And I think Jenny's very brave, isn't she, to explain her story about her dilemmas. And I think it really acknowledges all of the discussions this time last year about how safe vaccinations were. And it's been really interesting from a sort of a global and a scientific viewpoint that we now have, I heard on a podcast today, information of 390,000 women who've had the COVID vaccination, mainly from statistics in America, where they gave the vaccine to pregnant women right from the start, and then around 90,000 vaccinations from the UK. So I think we do feel very confident that the vaccine is safe, and any complications that may happen are the same if you were pregnant or not. So I think that's really, really important. So the first slide that is on the screen at the moment talks about the fact that pregnant women are just as likely to get COVID as non-pregnant women. The slight difference is that obviously during pregnancy, the immune system is slightly compromised, and that's the reason why pregnant women can become more poorly with COVID. So in the same way as non-pregnant women, 2/3 of pregnant women with COVID have no symptoms, but the most common symptoms are the same as if you weren't pregnant, and that is cough and fever. And the risk of serious complications, as it says, is low, but there is an increasing evidence that pregnant women may be at an increased risk of severe illness. So I think probably the two things that are really important to remember is that we feel that the vaccination is safe in pregnancy, and that we know that the 235 women who have been admitted to ITU who are pregnant, none of those women had received both doses of their vaccination. So we're quite certain that vaccination has made a difference to those women who potentially are very poorly and need to go to ITU. I'm going to do a Chris Whitty, and I'm going to ask for the next slide, please. So this slide is a bit busy and a bit tricky to see. But again, I think the important thing really looking at the data here is that if we look from March, when the vaccination was starting to be introduced to the high-risk pregnant women, we can see that 98% of pregnant women who were symptomatic and who needed to go to hospital, they were all unvaccinated. So again, it does seem to have made a difference to women needing to be admitted unwell with COVID when they're pregnant. Next slide, please. This slide is, I think, quite useful. It shows the peaks, and we can definitely see that there was the peak in the summer when the lockdown rules were relaxed in July time. But we can also see that the first arrow shows when the more vulnerable women, those were the ladies with the high BMI who were slightly larger, the ladies who had gestational diabetes, high blood pressure, they were offered the vaccine at that time. And then you can see the next arrow shows when it became available to all pregnant women. And then we can see again with the lockdown rules that were relaxed and kids going back to school, that's when we ended up with the next peak there with the Delta variant towards the end of the summer. Next slide, please. I think this is a really interesting slide. I certainly feel that from my own experience locally, that in the first wave, we actually were very lucky. We didn't really see any women who were very poorly. The second wave, we started to see one or two. And then with the Delta variant more recently, we've had quite a few women who've needed intensive care. And also we did have a lady locally who required ECMO, and I'll explain that a little bit later in one of the other slides. Next slide, please. So this, where you can see where it talks about UCOS information, what we have in the UK is a sort of an epidemiological group based in Oxford who are able to gather information about normally quite rare diseases from all of the trusts in the country that offer obstetric care, and they coordinated a system so that we could report back to them any woman that we saw who was COVID positive, which has been really useful because it's meant we've been able to collate information quite quickly. And there are some fairly stark statistics here. It talks about more than 3,000 women needing to come to hospital who were pregnant, who had symptoms. And you can see that they were twice as likely to need a cesarean section than women who didn't have, who weren't admitted with COVID. 1 in 4 of those had pneumonia, and 1 in 5 of those needed respiratory support, which is when you need to have either CPAP, the non-invasive positive pressure ventilation, which is the masks you often see on the news, or even needing to be intubated, which is obviously when they need a tube to help them breathe more easily. We knew also that pregnant women were more likely to need intensive care support, and sadly 15 women have died. There's also a feeling, like the rest of the country really, that there's been a much more heightened anxiety amongst pregnant women, and I think we can see that in just general society. Depression and anxiety is really increased, the other thing that I did just briefly mention before is the need for ECMO. 20% of the women who were admitted to intensive care who were pregnant needed help oxygenating their blood and to give their lungs a chance to rest and recover. And that is quite complicated and normally is given in a tertiary centre. So I know, as I say, locally we had at least one person who needed to go to London for that. So people have been quite poorly, and that's true in the local area as well. Next slide, please. So I briefly mentioned it before. Who is most at risk? Older ladies, ladies who are larger, ladies who have other problems such as high blood pressure, diabetes, people who live in socioeconomic deprivation, and of course people who, particularly in the first wave, were exposed to lots of face-to-face contact, such as working in healthcare. So, and virtually everybody that we saw who was poorly was in the 3rd trimester. So that's in the last 12 weeks of pregnancy. And that often was the reason why the risk of needing to be delivered prematurely happened, because in that last trimester, if mums weren't improving with basic measures or more complicated care, sometimes we needed to deliver the baby to help the mum recover more quickly or stop her deteriorating. Next slide, please. So we, as I said before, noticed an increase with the Delta variant of women needing to come into hospital requiring intensive care support. So previously 1 in 4 had problems with pneumonia. With the Delta variant, it was 1 in 3. You can see the other statistics there. It was 1 in 5 initially needed respiratory support. With the Delta variant, it was 1 in 3. Only 10% needed intensive care support, but with the Delta variant, it was 15%. But it reports there no maternal deaths, which I think is still true from the information that I've been able to gather. Next slide, please. So looking at the women who have had their had COVID-19 and delivered, which is nearly 3,000, we can see that 1 in 3, so 1/3 of women had a preterm birth, and that means that before 37 weeks. And 5% of those were particularly early deliveries, less than 32 weeks. So it's no real surprise that 1 in 5 babies needed admission to the neonatal unit. And sometimes this was due to the fact that mums were still intubated, and so they obviously weren't able to stay with mum, and so they did need to either go to intensive care or have be cared for by a family member. So there was a real sense of separation, which was really hard, I think, for everybody involved. And there was a slight increase in stillbirth, which we know is around 1 in 100. So we have seen that if we sample blood in the placenta, that we have seen that there is evidence of COVID, spike proteins, etc., within the cord, and we have got evidence to say that when people have been vaccinated, there is a chance of passive immunization. In other words, the immunity can be transferred with milk. But I'm guessing that Dr. Payton will give us some more information about that. Next slide, please. So this is what we were just mentioning before, that there's the Delta variant, there was a 1 in 100 had a stillbirth, unfortunately, which is obviously has been really hard. And in the Alpha variant, there's a 23% increase in neonatal unit admissions. Next slide, please. I think this is a really useful slide because I think it shows what a difference the vaccination has made to the women who've needed to go to intensive care. You can see that pretty much 100% of women weren't vaccinated, in other words, hadn't completed their 2 doses. There was the 1.3% represented on this slide who'd just had the 1 dose. And we know that with just 1 dose, there's a 60% coverage, so it will help reduce that risk even with just the 1 vaccination. Next slide, please. So this is just my last slide, the summary. We know that these particular risk factors, ethnicity, obesity, age, and other comorbidities, as I mentioned before, increase the risk of hospitalisation and severity. We know that, particularly with the changing variants, we've been seeing a trend in increased risk of pneumonia and needing respiratory support. 1 in 8 women who are admitted need intensive care, and 1 in 3 have a preterm birth, and 1 in 5 babies need to go to special care. The next statement says that evidence of reluctance to use evidence-based medical therapies in pregnancy, I'm rather hoping isn't true any longer, in as much as the Royal College of Obstetricians and Gynaecologists sends out regular updates regarding safety of new and more novel therapies, which I think most trusts are very keen to make sure that we are using, and our ITU colleagues are really keen. So the doctors who work in intensive care are keen for us to use those medicines as well, because we know it makes a difference. So essentially the bottom line is, as we mentioned, vaccination is strongly protective against severe disease, and therefore we would encourage and be happy to discuss that with any person who's pregnant who wants to understand anything more about it. Okay, so I'm going to move on to Dr. Payton, who is going to hopefully introduce himself and carry on with the rest of the slides.
Right, I'm unmuted now. That always happens, doesn't it? Thanks, Jo. That was a very interesting presentation. Probably the best way to describe myself, I've been a doctor for many years, and when the pandemic started, I was working in occupational health, and I wanted to do something to contribute to the fight against the virus. So after an awful long recruitment period, I managed to be recruited as a vaccinator, and I worked as a vaccinator at the racecourse in Bath for a few months. And I then moved on to the job that I'm doing now, which is basically behind the scenes. I'm fielding queries from GP practices, from patients through the PALS, Patient Advice and Liaison Service, about the issues with vaccines. What vaccine should I have? When can I have the booster? Things like allergy come up all the time. So that's essentially what I do. So in terms of the prevalence, the number of infections across Bath, Swindon and Wiltshire, that's illustrated in this slide. So the numbers testing positive on the 6th of December, Monday, are shown in the blue columns. The numbers in the red stroke brown columns are the numbers over the previous 7 days, and then the green columns are the rates of infection per 100,000 people. And you can see that within the figures within Salisbury are higher than Swindon, and they're higher than Bath and North East Somerset, but they fluctuate from week to week. And overall, the rates of infection are slowly climbing, although they have leveled out, and they're not climbing as quickly as in other parts of the world, particularly Europe. And a lot of that is due to the successful vaccination programme in the UK. So can I have the next slide, please? Okay, so this again, these are figures from Monday this week. So over the last 7 days, 330,000 people have tested positive in the UK, and that's an increase of about 9%. What we are seeing a difference now with the early stages of the pandemic, before vaccinations came along, we were seeing very high numbers of infections, very high numbers of people being admitted to hospital, and unfortunately very high numbers of deaths. So with the benefit of the various vaccines, which have been going for getting on for 12 months now, we are seeing slowly climbing numbers of infections, but currently the numbers of deaths are falling slightly, and the numbers of people being admitted to hospital are falling. And that's really all down to the various COVID safety measures, and in particular down to the vaccination programme. So moving on to the next slide, if I may. So in terms of the vaccines, we essentially have two different types of vaccines available in this country. There is a fourth vaccine, which is the Janssen, also known as the Johnson & Johnson vaccine, which is authorised in this country, but it hasn't come into use. And the main difference with that vaccine is that it's a single dose. So the single dose is equivalent to the 2 doses for the other vaccines we're using. So kind of taking them in reverse order. The first vaccine that was available was AstraZeneca, which we'll look at second. Although Pfizer was available at around about the same time, but because the vaccine is less stable from a chemical point of view, the vaccine itself had to be deep frozen at something like -80 degrees. It then had to be transported and thawed and diluted. So AstraZeneca was much easier to store and distribute. It didn't have to be frozen. It could be kept in a vaccine fridge at the same temperature as a domestic fridge. So that was used widely to begin with. And then as time has gone on, the Pfizer vaccine and then the Moderna vaccine have taken over in terms of the vaccines provided in this country. So the way that Pfizer and Moderna work, Pfizer and Moderna are almost interchangeable vaccines, but they work because they are mRNA vaccines, and the M stands for messenger. So the RNA in the vaccine transmits the message from the vaccine to human cells on how to make the spike protein, which is the main antigen in the vaccine. I'll explain what in the virus. Sorry, I'll explain what an antigen is in a moment. But because the messenger RNA can teach our own cells to make the spike protein, that then stimulates our immune defenses to be able to recognize the spike protein as a foreign object and to activate antibodies to destroy it. And on the virus, the main antigen is the spike protein, and an antigen is essentially a piece of cell biology which antibodies in the human body recognize as a foreign object. So every disease, if you take flu, for example, the antibodies we use to fight flu can recognize the antigens on the various flu viruses, which change every year, which is why we have to have a flu vaccine every year. So moving on to the next slide, if I may. So the second type of vaccine, it essentially does the same job, but it's made in a different way. And AstraZeneca, which is an adenovirus vector vaccine. Vector is a means of transmission. So you might think of vector as another form of messenger, but the AstraZeneca vaccine works by using a completely different virus. It's a type of virus which is found in chimpanzees, and the virus is modified so that it's damaged, so that it can't reproduce, it can't multiply, and it can't cause disease when it's injected into people. And again, that vaccine is able to stimulate production of the spike protein by inserting the genetic material from the virus into host cells. That stimulates them to make the spike protein, and then the body's defenses can recognize the spike protein and damage, neutralize, destroy the virus when they recognize the spike protein on the virus. And the chimp adenovirus cannot cause disease, it can't reproduce, and in the same way, the mRNA that the Pfizer and Moderna vaccines use is destroyed, deactivated within a few days of the vaccine being delivered. So next slide, please. So this is the big question, do vaccines work? And I'll give you the short answer, yes, they do. So you'll see from the top line, it's a very, very high figure of adults who get antibodies, either from being infected or from vaccinated. And as an aside, we believe those people who have the very best level of antibodies are those who have both been infected, have actually had COVID and been vaccinated. And one of the questions we get is, if I've had COVID, if I've been very ill with COVID, if I have long COVID, can I be vaccinated? The answer is yes, and you definitely should be, because having one dose of COVID does not stop you getting a second or even a third. So in terms of vaccine effectiveness, we know that both types of vaccines are very effective against symptomatic disease, and that means they prevent symptoms, and they also have even higher levels of protection against severe disease, being admitted to hospital and dying. And that's really the big difference that the vaccination program has made. Many more people are not getting seriously ill. They don't have to be admitted to hospital, and many fewer people are dying from COVID now. And then moving on to the booster, we know that immune levels start to wane after a few months, probably after 6 or 7 months. But the early data on the booster shows that vaccine effectiveness is boosted to a very high level. And you can see the figures there, that the estimates are around 24 million infections and 90,000 deaths have been prevented by the booster program. So next slide, please. So side effects, everybody asks about side effects, and when we vaccinate people, we always tell them about the side effects. So all vaccines produce side effects. Sometimes side effects from the flu jab can be worse than the COVID vaccine, but the typical ones, usually pretty mild. People feel tired, they have a headache. Funnily enough, after our first doses, I suffered with a bit of tiredness and my wife suffered with headache, and neither of us got the other one. You can get a fever. You can get a fever up to 38 degrees after you've been vaccinated. That doesn't mean you've been infected with anything. That's just the immune reaction. You can feel chills, especially if you've got a high fever. And very commonly, you do get some pain or tenderness at the injection site, but it's not the sort of pain where you necessarily have to take painkillers. It's more the sort of pain which, if somebody nudges you or you bump into someone or you turn over in bed, you remember that your arm is sore. We don't get so much swelling at the injection site. And most of those side effects only last for about 24, maybe 48 hours. And we recommend that people take paracetamol. Paracetamol is a very good drug, both for pain and to reduce fever. But other drugs, including aspirin, ibuprofen, and antihistamines can be used. In my experience as a vaccinator, most of the people coming back for their second dose told me the side effects were mild, they were very short-lived, and most people didn't bother with any treatment. So moving on to the next slide. So in terms of safety of vaccination in pregnancy, which Jo has mentioned already, we now have a great deal of data to show that the vaccines are safe in pregnancy. And one of the early questions we got in the vaccination program was from pregnant women saying, why can't we have the vaccine? And an awful lot of pregnant women wanted the vaccine, but initially in the UK government did not authorize vaccination in pregnancy because of lack of data. So we waited until we got the data from the United States, and we got data on approximately 90 to 100,000 women from the United States who had been vaccinated during pregnancy, and that data showed no adverse effects whatsoever from COVID vaccination in pregnancy. And as a result, the UK government then decided that vaccination in pregnancy was safe. It was opened up to pregnant women, and we have been using it and promoting it ever since. And in terms of gathering side effects, there are information about side effects. There are robust systems in place, and we use a system called the yellow card system. So any suspected reaction to any sort of drug or any sort of vaccine is recorded through the yellow card system, and that data is gathered and analysed by the MHRA, Medicines and Healthcare Products Regulatory Agency. So if there was any problem with vaccination in pregnancy, that would show up through that data. And next slide, please. So in terms of the side effects, basically the same in pregnant women as people who are not pregnant. There is no evidence whatsoever that there's any increased risk of negative or adverse or problematic pregnancy outcomes from a lot of data that we have already. And Jo would be better to talk about the third point, but there aren't any reports of adverse pregnancy outcomes which don't have some other explanation, such as pre-existing obstetric complications. And I like the phrase lack biological plausibility. What that means is that some people have some sort of they have some sort of experience, and they link it to the vaccine in the same way that people link things to drugs or other things, allergies. But in most cases, you just can't explain that. But that's difficult to explain to people. Next slide, please. So there is a lot of misinformation about, and we know that there are people who are deliberately spreading misinformation about COVID vaccination and about pregnancy. But the data that we've got in terms of miscarriage, the data is that miscarriage is no different, the rate of miscarriage is no different to women who've been vaccinated compared to those in the general population who haven't been vaccinated. The yellow card system, which I mentioned earlier, doesn't show any pattern to suggest an increased risk of miscarriage or increased risk of side effects from the vaccine. there are reports of women having menstrual disturbance, heavy bleeding in particular, but so far, analysing that data, we don't feel that these disturbances are linked to the vaccine, but we continue to gather the data to see if there is any longer term pattern. We have no evidence to suggest there's any sort of effect or negative effect on fertility, and again, nothing to suggest whatsoever that sperm quality is affected by COVID vaccination in any way. Next slide, please. So this is just a summary. So just to finish off, some important points. So the vaccines that we use, or even though the AstraZeneca vaccine uses a virus, it's a virus which is purposely damaged and changed so that the virus cannot replicate inside the body. So there's no way that any of the vaccines can infect pregnant women or their babies. The vaccines don't cross the placenta. The vaccines are not found in breast milk, but the antibodies that the vaccines stimulate do cross the placenta, and the antibodies are found in breast milk. So another of the benefits of vaccination is that the newborn baby immediately gets a degree of protection from mother's vaccination. So that completes my section. So if we can move on to the next section. Next slide. I'm sorry, am I doing this one or?
No, I think it was going to be me.
Oh, right. So I shall hand over to Catherine.
Thank you, Colin. That was really helpful, really interesting. My name is Dr. Catherine Aldridge, as Sandy said at the beginning. I am a GP in Old Town Surgery in Swindon. I'm also the GP clinical lead for maternity across the region. So I'm just going to touch a little bit on some of the questions about which vaccine. So just to reiterate here that right at the beginning of the vaccination programme, obviously the advice was to hold back if you were pregnant, breastfeeding or trying to a baby. That is normal when we introduce any new treatment or vaccination or system, because we want to be especially cautious with that population group. And I know from some of the patients I've spoken to individually that has stayed with them as a note of caution. But just to reiterate that as soon as they'd managed to collect some data to look at that, the advice changed completely the other way, and it has since then been strongly recommended, as I think has been sort of discussed already by government, RCOG, which is the Royal College of Obstetrics and Gynaecology, and the Royal College of Midwifery. In terms of who's offered it, it is being offered at the same time as the rest of the population based on your age and clinical risk. So we follow national guidance on this, and that guidance is based on both health information and to a degree on logistics and global behaviours of disease and availability, and has sort of clearly changed over time. But it remains that you should be able to access based on your age and your clinical risk. If you think you have a particular clinical risk factor, so underlying disease or a health problem, and you think that you're uncertain whether you should be prioritised, then that is certainly a reason to talk to a healthcare professional, obstetrician, midwife, GP, who should be able to help you with that. Again, I think this is reiterating that there now have been at least 275,000 women who've received the vaccine, and we've not seen high risks of any safety issues, and I think that's been covered by others already. Again, just to confirm that you can have the vaccine at any time during pregnancy, after the birth, when breastfeeding, when planning for a pregnancy. ultimately we don't believe that there's any risk at any point. The best protection that we can see is to have it as soon as you are able to access it, and then you're likely to get the most benefit from it. So there's no reason that you shouldn't have it in any of those circumstances. At the moment, the preference is for the Pfizer and Moderna vaccines. Some of that is to do with logistics and availability. That has changed over time, but also, as I said, through the organisations who are collecting data and making recommendations. Next slide, please. So again, looking at these things, some of the details. If you had AstraZeneca first time round, and of course, unless you had a serious side effect, which thankfully is usually very rare, you can have that as the second dose, even if the Pfizer and Moderna are generally offered in preference. Again, it's not because we think there's a particular risk. So if you can access the AstraZeneca as a second dose, then that's absolutely safe. But again, it may be to do with availability. Once again, I'll reiterate, if you have a particular issue, clinical concern, health issues you have, or side effects or problems you had after a previous dose, then absolutely please speak to someone who is your health professional, and they can look at that in detail. The guidelines, as you may have heard, have very recently changed to say that booster vaccinations can be offered after 3 months. It previously was 6 months, and that's so that is now across the board. It is safe to have at the same time as your flu vaccination. So many of you may already be aware that we have for some time now been offering flu vaccinations to big parts of the population, including those who are pregnant. So you can get them at the same time, and that's considered safe and a sensible thing to do. Again, the access is set as per the national guidelines. So although we say you need a minimum of a 3-month gap from your second dose to get your booster, you will still be eligible based on age and clinical risk as per sort of the national criteria. In order to actually access that, we recommend looking at the National Booking Service, which you can look up online. You know, anecdotally, of course, we come across sort of glitches and issues with that, but that is where most people are booking their appointments, and most people achieve that successfully. It is much more unusual to be able to offer walk-in appointments. A lot of that is to do with the logistics. So the vaccinations are globally in demand, and there's a big kind of a group of people behind providing them to try and make sure we have supplies to the right places with the right people, with the right staff, and the right facilities to store them and deliver them. And it's harder to provide that to walk in or in places that are outside of the big centres where they've now concentrated those efforts. Once again, if you've got any problems or questions that are specific to you, then of course you can speak to your healthcare professional. Next slide, please. And this is just a touch on the protective measures that I'm very hopeful that you've all heard plenty about. And these are things that we can all do to try and help prevent ourselves and other people catching COVID. So, so it's to wear a face mask, that's recommended, and certainly in healthcare settings, to wash your hands frequently, maintain distance, and certainly when you're in crowded areas, consider wearing a mask, even if you're outside. If you are inside, we recommend ventilating the area, as we know that if there's plenty of airflow, that reduces the risk of catching things. And just to touch on regular testing, it is worth keeping abreast of the recommendations in your local hospital or maternity setting about recommendations for having a lateral flow test before appointments. currently we would always ask if people are willing to do them, that it would be a good idea, and the more people who are willing to, the less likely we are to come across unexpected infections. And of course, currently our recommendation is to vaccinate. We appreciate that you know, this is why we're here to talk about it, to kind of answer any questions that you have. Next slide, please. So this is just some references if you want to have a further look. I believe that this information will be shared, can be shared by email, and as I said at the beginning, this will be recorded, so you can have a look at these at another time, take down the details. So the top two are probably the most useful. The top one is the government website that has information specifically about pregnancy and breastfeeding. And the second one, RCOG, is the Royal College of Obstetrics and Gynaecology, and they have produced a useful decision aid that can help you if you're uncertain what's the right thing for you, just to go through some information that kind of help you work through that thinking process. So as I said, you should be able to get these after this webinar's finished, so that you can have a look at them in your own time. Next slide, please. This is just to acknowledge where a lot of our information has been taken from. We're all health professionals, we work in this area, we work using this information, but there are sort of other outlets that have given similar webinars and information, to acknowledge where we've borrowed that from, but also just to say that hopefully this is a consistent message of information that you're hearing. It can be very confusing. I appreciate that you hear different things from different places. Next slide, please. And again, just some references, just to acknowledge where we've taken the information. Thank you very much.
So I'd like to say thank you very much to all of my colleagues who have presented some of the information, and we just wanted to give an opportunity now to pick up around some of the questions that have been put into the questions and answers. So I can see that there have been a couple of questions asked relating to where vaccines can be obtained from. So there was a question asking to us to explain why midwives and it said midwives and GPs are able. I think it probably means are not able to give the vaccination to pregnant women who want it, about that it would make sense for this to happen, as often it's a question of logistics and preferring to have treatment from someone you know and trust, and that's very similar to another question around, could women 15 to 50 be prioritised in future, so women are less likely to have to make a decision on whether to vaccinate in pregnancy. So I'm wondering if any of our panel would like to answer that question around, and maybe Colin, that I think you touched on it in your presentation, but around the logistics, didn't you, of where the vaccines are stored, the training that professionals need to have in order to deliver that vaccination. I just wondered if you want to pick up on that question.
Okay, well, there are essentially four types of vaccine centres. There are the large vaccine centres, which in Bath is at the racecourse, in Swindon is at the Steam Museum, and in Salisbury is at the Salisbury City Hall, and they will vaccinate sometimes 1,000 people a day. And with the development of the Omicron variant, and people all of a sudden, everybody wants their boosters, there used to be walk-in appointments, but walk-in appointments are really not available most of the time now. So the best thing is to go to the National Booking Service, which Katherine described, and book an appointment, and that will give you the opportunity to book your appointment at whichever centre is nearer to you, or whichever of those centres you want to go to. And besides the large vaccination centres, there are PCN, primary care network centres, which are run through GP surgeries, or sometimes where GP surgeries have combined to use a facility within a town. So there'll be a reasonably large service there. And then the other type of centre is those which are run by local pharmacies, which again tend to use buildings where a number of pharmacies can combine and provide a service. But all of those are available through the National Booking Service, and that is the best way to book a vaccination, and you'd be able to book it at the time and the centre of your choice, depending on what's available.
And I think, Colin, there was a question that I answered in the chat earlier from Sarah, I think, who, oh no, Sarah, it was somebody else actually who had struggled to book. Sorry, I think it was just looking to see they struggled to book their appointment. And certainly I've heard recently, and I've had the same in one of my family members, that actually some of the emails about eligibility are going into the junk email boxes and spam boxes. So just to say, check your emails, because you may find that I've heard that quite a few times from people over the last couple of weeks. So maybe worth having a look for those who may have had trouble booking. I hope that's answered your question. We will open that up in the moment. We have another question. There are a couple of questions actually that have talked around somebody who's had Sophie with an irregular period after the vaccination, and somebody's also asked if there could be more information on the research coming out about vaccines and menstrual cycles. Jo, I wondered if you would be happy to answer that question or at least update.
Yeah, sure. I think we're definitely gathering evidence that this is happening after women have had COVID infection or the vaccine. It's not that common, but we're looking at collecting data across the country. And the data that we do have suggests it's very temporary, that it's only lasting for 1 or 2 cycles. It doesn't appear to affect fertility at all. Well, we can see that with Jenny's story, so that was a good illustration. We know, and we also know it doesn't affect miscarriage rate from all the evidence we have either. So I think we can say it's safe. I'm not sure we've actually got down to whether it's the mRNA getting into the muscle of the womb or whether it's something to do with a vector, or I don't think we've quite got to that stage yet, but it's certainly something that is temporary and is hopefully we'll have some more information as time goes on. I hope that answers that. Thanks,
Jo. We have another question around, has any mRNA been found in breast milk? Are there any of our panel members that would like to answer that, or would you like me to answer that?
Yes, I'm happy to answer that.
Thank you, Colin.
No is the short answer. The mRNA in the vaccine is deactivated and destroyed within a few days of the vaccine being injected, and once it's done its job by delivering the genetic coding to the host cells, to the human cells, it then degrades within a few days. So there's no way that it can appear in any other parts of the body, and no way that it can appear in breast milk.
Thank you, Colin. We have a couple of questions as well around, does the vaccine have any side effects on breastfeeding the baby? And I think we did mention that during the presentation, to say that there is no evidence of any effect on the baby. And in fact, we're starting to get some evidence of suggesting that actually the breastfeeding from some of those antibodies that are produced that can protect the baby may pass over to the baby. So the short answer, I think, to that is no. And that's probably the same answer as well to the question, is there any side effects for your baby in the long term? And the evidence that we have is suggesting that there are no side effects for the baby, and potentially you're actually protecting your baby by protecting yourself not to have COVID-19 in pregnancy. So hopefully that answers your questions. We have a question around a new organisation called the World Council for Health, and What I would just like to say about that, the website, it wasn't known to me, and I'm not sure, or any of my other colleagues are all shaking their heads. So what I would say is you will come across information, and always check the source of your information. And I think it's, I've just had a quick look while we've been on the webinar, and I think what's really interesting is when you read the disclaimer on some sites that say information is provided with the understanding that the authors are not engaged in rendering medical, pharmaceutical or any other professional advice or services. And our advice is always to follow the professional bodies of this country, which is the information that we presented today. So I think always check the source of your information. We're not aware of this website in terms of the validation, so we can't comment on the legitimacy without reading all of that, but certainly they don't enter into any of our professional bodies' recommendations. So I hope that answers your question.
I have come across that.
Have
website.
You, Colin?
Yes. And we know that it's an unregistered website, and everything you've said, I would reinforce absolutely. You do have to be very careful about everything you see on the internet, but particularly health-related information.
Yeah. Thank you, Colin. And we just had a couple of questions around the actual vaccinations from Sarah asked a question. She'd had 2 COVID vaccinations with AstraZeneca in pregnancy, with the baby being due in February and is due a booster in January, but is concerned about having a different vaccination, especially in the 3rd trimester, and asked about the risks of mixing vaccinations in pregnancy. I'm just wondering, are any of our panel happy to answer that question? Colin, yes, thank you. Yeah. I can see it. Didn't want to put you on the spot, but thank you.
Now this is a regular question that we get. The data that we have shows that where people have had AstraZeneca for their first 2, if they have Pfizer or Moderna for their booster, then they actually get a slightly better response. And there's nothing to suggest any adverse effects. So for that reason, Pfizer is recommended as the booster in all cases, unless there's any evidence that someone might be allergic or have a reaction to Pfizer. So really the only reason for giving AstraZeneca as the booster would be in someone who had Pfizer for their first 2 and had a serious anaphylactic reaction to that.
Thank you, Colin. Thank you.
Just to make the point, there's no risk from doing that, which I think was part of the question. There is actually a benefit. With the 3rd dose being Pfizer, you get a slightly better immune response.
Thank you. We had one more question regarding somebody who had their first vaccine in March, and prior to being pregnant, they're now 35 weeks pregnant. I'm keen to have their second vaccine as soon as possible after a planned cesarean section in the 1st week of January. Due to the time lapse between the 1st and 2nd dose, is there any advice on the protocol of whether they need to start the course again, have 2 doses and a booster, or whether to have the 2nd vaccine and then the booster in 3 months?
Again, I'm happy.
I was going to say, I suspect that's yours. You're doing very well here, Colin.
You know, unless anyone else wants to. Again, that's a common question, and the advice is that if your 2nd dose is delayed, you should go ahead with the 2nd dose whenever. And generally speaking, the 2nd dose should be the same vaccine as you had for the 1st dose. And we know if you give a different vaccine for the 2nd dose, you tend to have slightly worse side effects. So if this person had AstraZeneca for their first one, they should have AstraZeneca for the 2nd one, and the same with Pfizer. But what you don't do, you don't start the course again. So the plan would be 2nd dose at the time the person has chosen, and then their booster in 3 months.
Okay, thank you. I'm just conscious of the time. I mean, if the panel are happy to continue answering questions for a couple of minutes, is that okay? We just have a couple more that have come in. the national booking system with around the boosters. So there's a particular issue that Julia's raised around that the national booking system doesn't allow to say you're pregnant. And therefore, because you're not over 40, you're not yet eligible. Colin, I just wondered if that's something that's come.
The way the boosters are being allocated, what we're all concerned about when the government suddenly changed from 6 months to 3 months because of Omicron, which is, I mean, that's only a few weeks ago now, but there are still a lot of elderly people and a lot of immunocompromised people who haven't had their booster. So we were concerned that all of a sudden fit, healthy young people would be streaming into vaccination centres, and there wouldn't be any slots left for those who were at higher risk. But in fact, the way that the vaccinations are being allocated is the same as when we first started back in December last year, and it's being done in waves in terms of risk. So younger people will not be able to get their booster probably until January or February, because we need to get the older people and the people with other medical conditions, immunocompromised people, vaccinated first. And there's also a lot of people, there's several hundred people in the Baines BSW area who are housebound, and they cannot come to vaccination centres. So we have teams going out to vaccinate them, and housebound people are at risk, and they have to be done before younger people who are less at risk.
Thank you.
But everyone will be able to get their booster. All adults will be able to get their booster in due course.
Thank you, Colin. I think it's always that demand. We know that the demand is very high at the moment, isn't it? And we're pulling out all the stops across every organisation and every system to deliver that as fast as possible. So I think you know, it is a huge task, isn't it? And
it is.
So
as you say, there's a lot of work going on.
There is. Everybody's trying. They're very
going
to do that. So thank you. We're going to take is that somebody's asked a question saying that children under 3 have been advised not to have vaccination. So sorry, my questions have just gone on to the answer questions. They say that children under 3 aren't safe to have the vaccine. So why is it safe for an unborn baby to get antibodies from the vaccine through the mum receiving it?
I don't know of any data that shows that it's unsafe for little children, but the vaccination is given on the basis, you have to balance the risk of COVID in general across the population against the risk to the individual. So the reason that vaccines start at the age of 12 is that the younger you get, the less likely you are to be seriously ill with COVID. And serious illness in young children is very, very rare with COVID, so that there isn't the same imperative to vaccinate them as there would be for people in their 40s, 50s and 60s. But I'm not aware of any evidence that the vaccine is dangerous in young children.
No.
And there is good data that we've presented that shows children, babies who are born to women who are vaccinated don't have any adverse effects from that or from breastfeeding.
Thanks, Colin. I'm just going to, I think we've answered most of the questions in the question and answer, and I'm just going to ask my colleagues, we're going to unmute whether there are any hands up for any questions before we just complete the webinar today by asking our final question. So Ruth or Gemma, are there, I can't see any hands up on my screen, but
no,
okay, okay. So if we can just move on to the last slide then. I hope that you have felt that today's session has been helpful. If you are currently pregnant and you need any more advice, please talk to your midwife or your obstetrician or your GP or a health professional, any other health professionals you're accessing. And as we said, we will make the information available. If you're not already following it, we advise you to follow the BSWCCG Facebook page and also the BSW Maternity Voices partnership page, where we share videos and information. We want to ask you the same question that we asked you at the beginning of the webinar about how do you feel about COVID-19 vaccination in pregnancy before we finish today. And whilst you're doing that, I also want to say that we are going to send out a survey following the end of the webinar, and we would be really grateful if you could complete the survey, and this will help us to understand if the webinar has been useful to you. So we'll just let you all complete that, and we'll have a quick look. So it's very heartening to see that we've got a difference from when we started out the webinar earlier on. So glad to hear that this has helped you, hopefully, and hopefully you can utilise the sources, the resources that we have put on the slides. I want to say a really big thank you to my colleagues who have supported this webinar, both our communications team and also our clinicians who have all worked all day and then come to join us because they all feel so passionately about making that information available. So a big thank you to all of you, and we stay well, and if you're pregnant, we hope to see you soon in one of our services, well and healthy, having a lovely baby. And for those of you who are health professionals, thank you for joining us. And if you require any more information, I'll ask my colleague Gemma or Ruth just to tell us who they need to email.
Yeah, if you have a look in the chat, I've posted a link that says if anybody's got any questions, you can send them to, you'll see it says bswccg.engagement@nhs.net. And also anybody that sent in the email to be registered, that came to that same inbox. So you can use that email address and I can pick it up that way as well.
Thanks very much, Ruth. And we'll post the links into the chat as well so that you can access those. So a big thank you. We're going to say good night. Enjoy the rest of your evening.